All right. Welcome to One Sheet Neurology. You all know the rules by now. We got one sheet of paper, we got one topic, and today we're going over ischemic stroke etiology. We'll be paying special attention to the TOAST criteria, which helps outline the five subclasses of ischemic stroke causes. However, to everybody's discomfort, the five subclasses have nothing to do with the letters in the acronym TOAST, making it very inconvenient. And I instead would encourage you to use the second acronym, ASCO or ASCO, to remind yourself of the causes, which are atherosclerosis, in particular large artery atherosclerosis, small vessel disease or small vessel occlusion, cardiac or cardioembolic causes. I would put a star next to that one to remind yourself these are kind of the big dogs. These are the big, scary, severe strokes. Other, which we'll go over, and then the last cause is unknown or cryptogenic. We'll quickly just get that one out of the way since it's not very educational. But in order to say a patient had an unknown cause of stroke or it's cryptogenic, you either need to not evaluate the patient, have an incomplete workup, do the full workup and have everything return negative, or do the full workup and find out that there's two possibilities. There's evidence that supports two different etiologies. The first thing to consider is the stroke syndrome the patient presented with, or the clinical presentation of the patient. In particular, is there any signs of cortical involvement or cerebellar involvement versus is the presentation consistent with the lacunar syndrome? For cortical symptoms, I like to remind myself of the mnemonic VAN, vision, aphasia, and neglect. And for cerebellar, I think about it, things like limb ataxia, gait ataxia, and vertigo. For lacunar syndromes, in your test, you'll want to be looking out for things like a pure motor stroke or a pure sensory stroke, which would correlate with the basal ganglia versus thalamus, respectively. I would just make a disclaimer that in real life, you can find pure motor and pure sensory strokes from small cortical lesions. And then I would also keep in mind that the thalamus is the great mimicker and can often present with cortical signs. Moving on to imaging considerations, we again want to consider whether the location of the infarct is in the cortex or the cerebellum, or if it is subcortical, whether it's greater than this size, the cutoff of 1.5 centimeters, versus if it's in a subcortical area or the brainstem and is less than 1.5 centimeters. Other testing we're going to consider includes things like vessel imaging, in particular, whether there's evidence of extracranial ICA or vertebral artery stenosis. Um, Next, we want to consider whether there is any cardiac source that would explain the stroke. And you're probably wondering at this point what that is. We'll go over those in a couple minutes. And then another wastebasket term of other, which we will define as we go. Moving on, we can explain how each of our stroke etiologies fits into this table, um, outlining the atherosclerosis, small vessel disease, cardiac or cardiobolic, and other cause of stroke. For atherosclerosis, due to a large artery disease, we would expect the clinical symptoms to be consistent with a cortical or cerebellar lesion and see those associated signs. Imaging would reflect the infarct in that area or being greater than 1.5 centimeters, and you can see extracranial atherosclerosis in the carotids and verts. Small vessel disease is basically the opposite of that. Cardioembolic causes are similar to large vessel territories, but note you won't see atherosclerosis on vessel imaging. Instead, you'll have evidence of a cardiac source. Those sources can include things like atrial fibrillation. I would pay special attention to valvular atrial fibrillation since it's managed differently, which we'll go over in a separate video. Valvular AFib we define as being a patient with AFib in addition to severe mitral stenosis or the presence of an artificial heart valve. Low ejection fraction is a risk factor, as well as recent myocardial infarction within 4 weeks, the evidence of PFO, and then lastly, I would include infective endocarditis. Your other category is basically a hodgepodge in terms of the clinical and imaging presentation you can see, but note you will have evidence of some other cause of stroke. And you will not see a cardiac source and you will not see extracranial atherosclerosis. Those other causes can include things like vasculitides, whether it's due to an infection or due to an immunologic cause, like, say, primary cerebral angiitis or secondary angiitis due to lupus or other rheumatologic disease. The patient might be hypercoagulable, either due to an acquired hypercoagulability like pregnancy, cancer, or malignancy, medication induced like contraceptives, or it could be congenital like antiphospholipid syndrome or factor V Leiden mutation. And then I would include a couple of hematologic and vascular abnormalities like sickle cell disease, moyamoya disease, and dissections, whether in the carotids or the verts. So there you have it, folks. Those are our 5 classes of ischemic stroke etiology. Once again, the TOAST criteria helps you delineate the cause of the patient's stroke by considering the clinical signs, the location and size of the infarct and imaging, and then ancillary testing that can show you evidence of atherosclerosis, evidence of a cardiac source, and if neither of those are revealing, um, some other testing does check for things like vasculitides, hypercoagulability, and these other hematologic abnormalities. So that's it for today's video, but in a future video, we'll go over how to manage these conditions, as really the name of the game with figuring out what caused the stroke is knowing how do you prevent the next one for these patients. Lastly, I just flash up there the risk factors for the atherosclerosis and small vessel disease. For small vessel disease, you'll think about things like smoking, hypertension, diabetes. These can contribute to microvascular disease or lipohyalinosis. And for large artery atherosclerosis, you'll add hyperlipidemia. I did circle and highlighted the NASCA criteria since it's an important consideration for a patient with ICA stenosis. You'll consider whether it's greater than 50% with symptoms or greater than 70% even without symptoms. But as mentioned, we'll go over management in a future video. And then as a final comment, I will circle back to cryptogenic stroke and give a common example of how a patient could be found to have 2 possibilities or 2 likely etiologies of the stroke. Say, for example, you have a patient with a left MCA territory stroke, and you find that they also have critical left ICA stenosis. However, they do have atrial fibrillation. It'd be very difficult for you to say which one of those is the cause of this patient's stroke. So that's it for today's video. Those are the TOAST criteria for the 5 classes of ischemic stroke etiology.